with Dr. Joseph Uberti. For those of you that don't know me, I'm Michelle or Mickey McWilliams, and I work with Sid Moss at Cure Multiple Myeloma Corporation. Before we begin, I'd like to ask you to please put your devices on mute unless you want to speak. That cuts down on the interference noise because sometimes we'll get like reverberations. We are so pleased to have Dr. Uberti with us today. A specialist in medical hematology and oncology, Dr. Uberti is Division Chief of Hematology and co-director of the Bone Marrow Transplant Program at the Barbara Ann Karmanos Cancer Institute. He's actively involved in clinical research in bone marrow and peripheral bone stem cell transplants and is the expert to answer your questions about transplants as part of a treatment protocol for multiple myeloma patients. Get these people in here. Hold on, sorry. Before we begin our discussion, I'd like to thank our very important partners, Oncopeptides, Karyopharm Therapeutics, Sanofi, Bristol Myers Squibb, Adaptive Biotechnologies, Amgen, and Dova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to acknowledge Sid Moss. Wave your hand, Sid. The founder of Cure Multiple Myeloma Corporation. Sid and his organization are responsible for our breakfast snacks. So, thanks, Sid.
That's for concessions on the price because of something we're going to say, we're going to want, not the report, we're going to want the.
So the way this will work is Dr. Uberti will provide us with a little background on himself. Then he'll give us an update on treatments and any other news as it relates to multiple myeloma. Then we'll open up to questions from you. Please use the chat button to type in a question anytime during the discussion. I'll read all questions sent to me in advance, which I do have some, and from the chat. Plus we'll unmute and take questions from the floor. So, thank you for taking the time for the Zoom session, and take it away when you're ready, Dr. Uberti.
Well, thank you, Mickey, and thank you, Sid, for inviting me back. This is, I think, my third or fourth time meeting with everyone, so thank you very much. I hope you can hear me well. And so what I focus in is stem cell transplant for all the hematologic diseases, including multiple myeloma. We also run all the CAR T cell therapies through our program as well. So all the CAR T therapies for all the various hematologic diseases that are now approved for, as well as stem cell transplants, all run through my little division here. So we do a lot of transplants for multiple myeloma, about 120, 130 a year. We also have several clinical trials open for the treatment of multiple myeloma using CAR T cells. And just 2 weeks ago, I think, CAR T cells were approved by the Food and Drug Administration for the treatment of multiple myeloma. So as one of your sponsors, Bristol Myers Squibb, their product was approved based on their most recent study for the treatment of multiple myeloma. And that was just, I think, 2 weeks ago when that approval came through. So that was an exciting thing, I think, for patients with multiple myeloma, that there's another new cellular therapy that's available that can be used for the treatment of multiple myeloma. So that's where we are in terms of new developments in terms of cellular therapy. And as you know, there's a ton of new treatments available for multiple myeloma that come out at a dizzying pace almost. So I focus mostly on the CAR T cell business for multiple myeloma, as well as the stem cell transplants for multiple myeloma. That's my area of expertise.
Well, I mean, it's far from clear. I guess we're not in agreement with that one yet.
There, I'm gonna unmute.
Oh, okay. So I'd be happy to talk about any of these issues, what everybody would like to hear about. If you want to hear about the CAR T cell therapy, maybe that's where we can start, because that was the most recently approved therapy for multiple myeloma. So in terms of how the FDA looked at this, in order to be eligible to get CAR T cell therapy for your multiple myeloma, you have to fail 4 different therapies. So as an example, if you do a transplant and maintenance therapy, that's one therapy. So you have to fail carfilzomab, you probably have to fail daratumumab, and you have to fail one more additional therapy in order to be eligible for CAR T cells. So the FDA has approved it in that situation. Now, I know I probably spoke about this several times because we've been doing research on this for a few years. CAR T cell therapy is where they take out your lymphocytes out of your bloodstream, and they send it off to a manufacturing facility that injects into your lymphocytes a piece of DNA that is integrated into your lymphocyte DNA, and it makes a small molecule that's on the surface of your lymphocytes that targets and kills myeloma cells. So it takes about 3 weeks to grow these cells, infect them with this viral type particle, and to make sure they meet all the quality criteria to be released to us, back to us. So once we get the cells back to us, we start the process of giving patients CAR T cells. Again, this was just approved 2 weeks ago. So we don't have any yet who've got the commercial product, but we've had about a number of patients who've got the product under investigational trials. So to get the cells, what you have to do is get some mild type of chemotherapy, and that goes by the term of lymphodepletion chemotherapy. You get 3 days of it as an outpatient, and the 2 chemotherapies we have to give before we give the CAR T cells back are fludarabine and cyclophosphamide. Now, some of you may have had cyclophosphamide as part of your treatment for multiple myeloma. As an example, in the Cyborg-D regimen, the Cy is cyclophosphamide. So many of you may have had this chemotherapy before. The other chemotherapy we have to give before giving the CAR T cells is called fludarabine. They're administered for 3 days. They're all administered as an outpatient. And generally, we wait a couple of days. And after a couple of days, we bring the frozen CAR T cells up to your room. And it comes in a very small volume. It's probably less than 50 cc's. And we infuse it into you, and it goes in quite quickly without too many complications. There's some unusual toxicities that can occur with all CAR T cells that have been proved for 5 different diseases and now multiple myeloma. And those unusual complications have also been seen with the administration of CAR T cells for multiple myeloma. Now, they do, hold on, let me just silence my phone here. Give me 1 second. So what the multiple myeloma CAR T cells target is an antigen on the myeloma cells called BCMA, B cell maturation antigen. So the CAR T cells, after they're administered, attack those cells, those myeloma cells that have this antigen on the surface. And when they bind to the myeloma cells, CAR T cells expand like crazy, actually, making duplicate numbers of CAR T cells that can in turn kill more and more myeloma cells. So in a way, it's more or less of a living drug that expands in your body after the infusion into the system. And what happens when they start expanding, they release a lot of small molecules called cytokines into the circulation. And those small molecules can cause one of the initial symptoms of CAR T cell therapy called cytokine release syndrome. And patients may get fevers, they can get low blood pressure, low oxygen level in their blood. There's a lot of things that can happen when you get one of these first complications. And in the most recent studies, over 50% of the patients get some form of this initial toxicity called CAR T cells. And this can be treated with a drug called tocilizumab, which we do routinely with all our CAR T cell patients. The second thing that happens, the other toxicity, is some neurotoxicity. And that can be quite varied. By neurotoxicity, people can develop confusion, they can stop speaking appropriately, they can even have seizures as part of the toxicity that we see in CAR T cells. And that can also be seen in the CAR T cells used for multiple myeloma. And that can be treated also. And those are 2 toxicities we see with CAR T cells with multiple myeloma. And we've also seen them with CAR T cells for all the other diseases we use. So it's something we're sensitive to, something we know how to treat, but something we have to be very cautious about as well. So the response of CAR T cells in the situations that we've looked at so far, and remember, these are very highly pretreated patients. So the response rate is fairly good. About 70% of the patients who had the administration of the CAR T cells that were approved by the Food and Drug Administration had a good response, and about 33% of them had a complete response. So a third of all the patients who received the CAR T cells went into a complete remission. And remember, these are patients who have failed a lot of therapies. The average number of therapies that patient failed on these clinical trials is now about 6 different types of therapy. So the response rate is good. The complete response rate is good. And the new term we use is talking about minimal residual disease, or MRD negativity. And that's the most sensitive test that we have to look for available myeloma cells in your body after therapy. That about 24% have MRD negativity. So a lot of people respond, a lot of people develop a complete response, and a lot of patients actually have MRD negativity after the administration of the CAR T cells. So those are very encouraging things that we saw after the administration of CAR T cells. A little bit more disappointing, I think, is how long they last. So we are hoping they would last a fairly long time, but it looks like they last about 9 or 10 months right now. That is, once you responded, the response only lasts about 9 or 10 months on average. Some people do respond longer, some people, the response is less, but that's what it currently shows. So it's good therapy. Part of the reason we may not be getting longer responses is being used so late in therapy. So we're using it only after patients have failed so many therapies that it may not be as effective as if we used it more upfront, more sooner or earlier in the disease course of patients with multiple myeloma. So that's where the new trials are headed. So the good news is there's the new therapy available for multiple myeloma. It does, patients have a good response. 33% of patients go into complete response or better. So a third of patients develop a complete response. Patients develop less than a complete response, but they do respond up to 70-80%. But perhaps, realistic news is that it doesn't last for a long time, that response to CAR T cells lasts a little bit less than a year on average with all the patients. So we'll obviously be looking for ways to improve that therapy, but that's where we are with CAR T cells. Again, it was just approved a couple of weeks ago. The company is gearing up to be able to have patients go on the trial, and we're gearing up to do that for patients who meet the eligibility criteria and may want to try this new therapy for multiple myeloma. Maybe I'll stop there and see what questions I could answer. We could also talk about transplant and what the role of transplant remains in multiple myeloma. But CAR T cells was the most recent thing that was just been approved by the Food and Drug Administration.
So I do have a number of questions here that have come in prior to this call, and then we also have some in the chat. The first one I have here is Carmano's bone marrow transplant program ready to accept multiple myeloma CAR T patient referrals from community oncologists?
So we are. So we're still getting geared up to get the company has to approve our ability to give the CAR T cells, and we're in the process of doing that. So they have to meet the eligibility criteria of having failed 4 therapies. So we are evaluating patients right now. We may not be able to do it, today or tomorrow, but over the next few weeks, we should be able to get things going to evaluate patients for CAR T cells. And remember, it takes a little bit of preparation to get the patients involved in these types of therapy. We have to make sure that the patient meets the criteria. We have to make sure the manufacturer has manufacturing capability to make the CAR T cells. So I say a cautious yes, we are ready to do this.
One question that I've seen a couple times is if this CAR T cells treatment only lasts for say 10 to 12 months, are these patients then eligible to have another treatment with it? Or what?
So right now, we don't have any evidence that another treatment with the current CAR T cells commercially available is going to be effective. So the answer is we don't think so. There may be other types of CAR T cell therapies they may be eligible for that use a little bit different ways of manufacturing the CAR T cells. So for the commercial CAR T cells, it's one and done, basically. But that doesn't eliminate you from potentially other therapies and perhaps other types of CAR T cell therapies.
Okay. Let me ask, we've got a whole lot of questions in the chat. This is really good, everybody. I mean, you're asking a lot of really good questions. This is one question is CRISPR, CRISPR, being investigated as a cure for myeloma?
So CRISPR technology is a new technology where we can cut out specific pieces of DNA and replace with other pieces of DNA. So that's in its infancy of where it's being used right now. So there may be some very early trials or early studies looking at this in multiple myeloma, but nothing I think are ready for prime time yet. And I don't think we have any investigational trials looking at CRISPR technology for multiple myeloma. But that may be something that we may be looking at in the future. CRISPR technology is very different than CAR T cells. It's also very different than all the other available therapies we have right now.
Well, another question is, what criteria must be met to qualify for a second BMT?
So there's a couple of criteria we use. What most people recommend is that if your first BMT, your first transplant lasts longer than 18 months and you progress after that, that's when we generally recommend a consideration of a second transplant. So if the first bone marrow transplant doesn't last at least 18 months, we don't think a second transplant is going to be any more effective than that, and it's probably not worth the hospitalization involved in a second transplant. But if it's beyond 18 months, I think most experts in the field think that a second transplant may be a reasonable option for patients who've had at least a response to the first transplant of that long.
Okay, here's another question in the chat. If and when CAR T fails, what is next?
Well, I mean, you have to look at what previous therapy you've been on and see what's available, what drugs you haven't been exposed to, what regimens you haven't been exposed to. There are certainly other regimens that you could receive after CAR T cells. It doesn't eliminate you from getting other types of therapy to go through a CAR T cell therapeutic maneuver. So one thing I should mention too, there is a BCMA antibody that some patients get too. So the BCM antibody, which is a bifunctional antibody called a BiTE, it also targets the same antigen that the CAR T cell targets. And whether or not you can get both of those is unclear because you're kind of hitting at the same target. So sometimes, as an example, in the clinical trials, patients who have received what's called the BiTE antibody against BCMA can be excluded from the BCMA CARs because they think if you've already received a therapy that's directed against that antigen on the myeloma cells and you fail that, a second therapy that's directed against the same antigen will probably not work.
Okay, another question here. With your new trials, what are the criteria for enrollment? How many treatment failures do you need to have? And this question says, I know you said 4 treatment failures now, but do these new trials allow fewer TX failures?
So that's true. So for the commercial product that's now approved, the FDA has mandated you have to have 4 failures. So we have to document the patients have failed 4 different things. On most of the investigational trials, patients have to have failure of 3 regimens, and one of those regimens has to be daratumumab or Darzalex. So Darzalex, you have to fail Darzalex. You can fail transplant, you can fail carfilzomab as an example. That would be 3 things you failed. So those are for the investigational trials. Unfortunately, when the FDA came out with the approval, they mandated you have to fail 4 therapies. So we've argued that the quicker you get CAR T cells into the patient, the better off they may be in terms of having a better response and getting a longer survival advantage and a longer disease. The FDA wanted us to only give it to patients who fail 4 therapies.
What phone number, and maybe what we can do is, this question is, what phone number and name of person should be contacted at Karmanos to enroll in the trials? And maybe what we can do too is I can send that out afterward. If
Absolutely, we can give you the numbers. Yeah. I mean, we have obviously other trials, other CAR T cell trials are up and running right now. So, we have to separate the commercial product from the trials. So the commercial product is available. They can give it to anybody who has failed 4 therapies. The investigational trials are also available for some different type of CAR T cells that we have open as well.
So I have a question. Does insurance normally pay for these the new therapy that's just out now?
So that's a more difficult question to answer. And we struggle with that a bit because insurance companies Well, especially Medicare, which many patients have with multiple myeloma, they haven't paid as much as we'd like them to pay for the CAR T cell products. As an example, the CAR T cells cost us $419,000, I think. So just for us to buy the CAR T cells, we have to pay 419,000 or 410,000. I don't remember the exact number. And insurance companies, well, Medicare in particular, has elected not to pay us for that in full. They've only elected to pay us for 50% in the previous CAR T cells that we've used. So that has made it a bit difficult for us to justify this financially. I mean, we in no center can start losing hundreds of thousands of dollars with each patient we treat. So that is an issue that we haven't come up yet with the CAR T cells for myeloma because we haven't treated a patient. But it might be a problem with CAR T cells for myeloma as it is with CAR T cells for every other disease indication. So how Medicare treats these things is a little bit a black box to us. So we don't know why they don't just reimburse us the entire amount we have to pay to get the cells.
Right. Do other insurance companies reimburse you?
Yeah, private insurances usually are a little bit better with insurances and reimbursement. So for the other CAR T cells that are commercially available, we do better with the private insurances than Medicare.
Okay, here's a few more questions that we have. How does the stem cell transplant chemo melphalan work against MM?
So melphalan is a different type of chemotherapy. It's actually one of the older chemotherapies that have been used for myeloma. It's what's called an alkylating agent, where it binds to and destroys the DNA of multiple myeloma cells. So it's very effective at killing off myeloma cells. When we do it in a transplant, we try to give it at the highest dose possible to kill off as many myeloma cells as we can. And the advantage of using melphalan is that it works by a different mechanism than the standard regimens patients get for multiple myeloma, such as Revlimid, Velcade, dexamethasone, daratumumab, carfilzomib. They all work by different mechanisms than melphalan does, which is a drug we use for multiple myeloma. And the advantage of using that type of drug is that patients' myeloma cells develop resistance to all the types of therapy we use. So that's one of the problems with all diseases, including myeloma, that patients become resistant to Revlimid, Velcade, dexamethasone, or carfilzomib, or daratumumab. And sometimes we can overcome that resistance by using melphalan because it works by a different mechanism. So that's the advantage sometimes of using a transplant, where you use a new type of therapy to kill off the myeloma cells. It goes under the class of agents called alkylating agents, which means it just binds to the cell's DNA and kills out the cell by binding and making their DNA ineffective. Now, unfortunately, it's not that specific for myeloma cells, that it doesn't hurt other cells in your body. So as an example, it'll hurt your bone marrow stem cells that are normal stem cells. So that's why we have to do the transplant. So when you give high doses of melphalan to kill off the myeloma, it's also very effective at killing off your bone marrow. So that's why we do the transplant. We give you the melphalan, we kill off the myeloma, we also kill off your bone marrow as a byproduct. So we have to take your stem cells and put them back into you to allow your stem cells to recover.
Another question here. Are you keeping patients on maintenance treatment indefinitely following transplant?
So yes, we are. So there's a little bit of controversy over that. So most of the data, I think, supports giving patients who have been through their first transplant, certainly. The most common maintenance therapy we use is Revlimid. And we do keep them on it indefinitely, but indefinitely really means we keep you on it until there's evidence of the myeloma coming back. And most of the data has shown is that's the best way to keep you alive and free of myeloma. One of the downsides of using Revlimid as maintenance therapy, however, is there is a risk of secondary cancers. And that risk of secondary cancers seems to be related to the use of Revlimid after the transplants for multiple myeloma. And those secondary cancers can be very severe. They can be, we've seen cases of acute leukemia, both types of leukemia we've seen. We've seen cases of myelodysplastic syndrome, another hematologic disease, all that we think are related to the use of Revlimid after the transplant. even with that happening, the patients on Revlimid do better. So we generally recommend for patients to stay on it. Now, the European regimens have been to stop Revlimid after 1 or 2 years, but we have not taken that approach here in the US. In the US, we do recommend everybody stay on it for as long as there's evidence that the myeloma is not coming back. With the realization, it may increase your risk of secondary cancers, which can be as high as 10% in patients who are on Revlimid as maintenance therapy.
Here is another question that came in earlier. I think it's LGG Kappa and started induction therapy mid-October 2019 after smoldering for 6 years. March of 2020, I was eligible for SCT, but decided against transplant due to COVID virus. Plus U of M temporarily stopped all SCTs. My blood numbers have remained stable, but I've been unable to lower my M spike below 0.6 for the last 8 months. What would be involved, or would it even be possible to have an SCT at the present time?
So yeah, the simple answer is yes. I mean, I need to know a little bit more specific. We need to know a little bit more specific. So, even though you haven't had the paraprotein go down to 0, you could still get a transplant and it could still provide a benefit to patients. Even patients who haven't had a response, even a PR or a VGPR or no response, do have a benefit from transplant. So the simple answer is yes, you still can undergo a transplant even though the level of the protein hasn't gone down to 0. And in fact, the transplant may bring it down to 0, again, because we're using a different way to kill off the myeloma cells. So it is a reasonable option. Now, sometimes people who are on a lot of therapy before the transplant, we sometimes have difficulty collecting their stem cells. So the more therapy you're on, sometimes it does make it difficult to collect stem cells. As an example, some patients get radiation for various plasmacytomas prior to collection of stem cells. And if that radiation is in areas where a lot of your stem cells live, that sometimes makes it harder for us to collect stem cells. Sometimes people who've been on Revlimid for a long time also have some difficulty collecting stem cells because stem cells do cause some damage on your stem cell population. So yes, we would think the transplant would be reasonable, even if that person hasn't had a better response than what she mentioned. We would need to collect the stem cells, and we think the administration of the new drug, melphalan, may be effective in killing off the myeloma cells that have been resistant to the current therapy she's on or he's on.
Okay. Okay, here's another one. Have you ever seen hematologists, oncologists treat multiple myeloma and breast cancer at the same time, i.e. Revlimid plus chemotherapy for breast cancer? What should be considered for side effects and treatment choices for the breast cancer?
So I'm not a breast cancer specialist, so I can't answer that question too easily, I'm afraid to say. But certainly you can undergo treatment for both diseases at the same time. We have a lot of patients we treat for 2 different diseases. I can't exactly tell you what the treatment for the breast cancer would be and how that would interact with the treatment for the myeloma, because I don't know what they use for breast cancer too much. I mean, certainly there are ways we can avoid overlapping toxicities and try to bring both diseases under control as best we can using the different agents we use for the different diseases. So that's the best I can say for that. It's doable.
Okay, let me just run through here and see if I missed any of these questions. That we've had a lot. I mean, keep asking questions, everyone. And you know what? Right now, I think I've looked through the chat and my questions here. I'm going to scan a few more to see if we've answered all these, because you've sort of answered them in different ways. So yes, Janet, do you have a question?
Yes, I wasn't, excuse me, I was not quite clear from your answer about a second bone marrow transplant. I did understand that you said once you've passed the 18-month part since your first transplant, you could go ahead, but I wasn't sure if you're supposed to wait for a relapse before you have the second bone marrow transplant, or should you just do it prophylactically as soon as you've passed the 18 months?
No.
If you're stable.
No, we don't recommend that, what you just mentioned. if you relapse within the first 18 months after a first transplant, then we're a little bit hesitant to do a second transplant. If the relapse occurs after 18 months, then we feel a second transplant may be more reasonable to think about doing. So we don't usually recommend 2 transplants prophylactically so much anymore. A number of years ago, that was more popular, that's a bad use of the term, it was done more frequently, that we do 2 transplants before patients relapse. But I think with the use of Revlimid as maintenance therapy, it's diminished the role of 2 transplants before patients relapse. I hope that answers your question.
And just to follow up, how deep should the relapse be? What would you say about which lab values and where they should be?
Well, I think when you need to start more therapy, that's what should define the relapse. So let's just say you're on maintenance therapy with Revlimid, and your paraprotein goes from 0.1 stable to 1. I mean, when you see an increase like that in the paraprotein level, or you see a new bone lesion, that would indicate you need to start more aggressive therapy. So I think that's what drives our thought about when a second transplant would be necessary. So when you go from maintenance therapy to more aggressive therapy, that's when we start considering a second transplant.
What kind of imaging would you recommend to determine the status of bone lesions?
I think most people are recommending a PET CT scan. Some insurance companies are balking on that, but I think a PET CT scan is a little more sensitive than the more commonly used bone surveys. So we usually prefer a PET CT scan. Again, if the insurance doesn't allow it, then we have to go with regular bone surveys and or MRI of various areas that may be involved, or patients have pain that can confirm diagnosis of myeloma if other imaging studies don't show it.
Do bone lesions show up even though the M protein level does not increase?
They can. So some people have a non-secretory relapse, which, just as you said, their levels of the blood aren't going up, but bone lesions can worsen. But that's usually heralded by pain or some other symptoms the patient's having. The simple way to follow myeloma is the patients have, levels in their blood that we can follow that makes it much easier for us to follow. Some patients don't have any levels in their blood to follow, so the only way we can follow them is by doing bone surveys or PET CT scans. But that's the unusual type of patient.
Thanks.
I did see another question here. Somebody asked about Pomalyst.
Yeah.
Does that contain all the risks mentioned when taking Revlimid, We don't think so. There isn't as much data on Pomalyst, which is kind of a cousin of Revlimid, as there is with Revlimid. So there's not as much data how effective it is as maintenance therapy as opposed to Revlimid, which shows to be very effective. But sometimes we have used Pomalyst in patients who can't tolerate Revlimid or have failed Revlimid without much data. It does not seem to increase the risk of secondary cancers, but that hasn't been as well studied as it has been in Revlimid, where there's a clear increase in secondary cancers.
There's another question here. Why doesn't Revlimid work against secondary cancers like leukemia?
Because it works by a different mechanism. So different cancers need to be treated by different types of therapy. So Revlimid is not a good therapy against leukemia. And how it increases your risk of a secondary cancer like leukemia is unclear. So it's not effective against that disease. And somehow it triggers a number of genetic mutations in the bone marrow that causes it to become leukemic. How it does that, we're not sure. But it doesn't treat leukemia, so it's not going to be effective in preventing that from happening.
Anybody willing to, just unmute yourself and speak up here, because I think that I've pretty much gone through the questions that were sent to me before and those that are in the chat right now. So unmute and ask a question if you'd like.
I've just looked through the questions. I haven't seen any other ones either.
Yeah, I'm trying.
Well, here's one. Can I read this question? My husband has both multiple myeloma and cardiac amyloidosis. He's on Cybor D plus DARA in clinical trial CAEL 101. Is Cyborg D plus DARE the only treatment for multiple myeloma, or is also treating amyloidosis? Is a primary health concern the amyloidosis or the multiple myeloma? Does the CAR T treatments only affect multiple myeloma? So let me answer the last question. I don't think CAR T cells have been shown to be effective in amyloidosis. So they're only directed against the multiple myeloma, patients that have multiple myeloma. I'm just reading over the other question. So when you treat amyloidosis and multiple myeloma, you're treating both diseases. So the Cyborg D plus daratumumab is a good regimen that seems to treat both diseases, the multiple myeloma, which is probably causing the amyloidosis, as well as the amyloidosis. If you think about what amyloidosis is, it's deposition of these abnormal proteins in various organs of your body. So that amyloidosis, this protein, can be deposited in your lungs, it can be deposited in your heart, it can be deposited in your kidneys. So this deposition of this protein causes the problems we see with amyloidosis. And it is those multiple myeloma cells that accompany this disease that is making that abnormal protein. So in order to treat this disease, you really have to kill off the multiple myeloma component that's making the protein. Now realize what that doesn't do, it doesn't take away that protein that's been deposited in your tissue. So that has to be improved over time. That is, your own body has a way of perhaps getting rid of that protein in your tissue that's been deposited by the multiple myeloma cells that has caused this amyloidosis deposition in your tissue. So there's two things you have to do to cure or improve amyloidosis, multiple myeloma: kill off the cells of the myeloma and hope that the body reabsorbs this protein that's been deposited in your tissue, causing the problems we see in amyloidosis. You know, they are working on ways to try to help that, try to help get that protein eliminated from your organs, from your kidneys, your heart. They haven't been as successful as I think we want them to be, but we're still looking at ways to do both of those things: stop the production and get rid of the protein from amyloidosis. Right now, it's being treated like multiple myeloma because that's the only way we know of stopping the production of this protein.
Okay, a few more have come in. What has been your experience with using Darzalex for a long period of time as maintenance?
So we've done that in spite of the fact there's not too much data on that, no formal data. You know, we look at investigational trials that show if you use Darzalex, that's going to be good as maintenance therapy. We think it's going to be good as maintenance therapy. The trials are just ongoing right now to look at the use of Darzalex. So as an example, we have a trial running that compares Revlimid as maintenance therapy to Revlimid and Darzalex. So patients are randomized to one or the other. So Darzalex can be used by itself as maintenance therapy. It can be combined with Revlimid as maintenance therapy. We don't know what the best way is to use it. We don't know exactly how well that works compared to some of the other regimens we use. It makes a lot of sense to all of us that would be good maintenance therapy. It may not have the side effects that are associated with Revlimid. It may not cause secondary cancers like Revlimid does, so it may have an advantage. Unfortunately, we don't have the formal data that shows that it's going to be a benefit yet, and how long to use that, and what's the best way to use that. Do you use it by itself? Do you add it with Revlimid? Those things will need some time for us to figure out.
So with all these things that we're talking about as far as these trials, perhaps what I can do is afterward get some information to let everyone know how they can, what the criteria is and how they can join a trial if they want. Is that?
Absolutely, yes. I mean, realize all the trials are different and they have different criteria for joining them. So it's hard to give criteria for everyone. You know, once they've been treated for myeloma and there are trials available for them, you know, usually they can do it for upfront therapy, they can do it for relapse therapy. There are a number of trials available to them, as well as other types of standard therapy. So we'll give you numbers to call. Let me just make sure I have the right numbers, and I could just email them to you, Mickey. And you can.
Right. Thanks. Yeah, that would be good. Or Lone can do it. I think she's out today, but she'll be back like tomorrow.
Yeah, I'll have her contact you.
Okay. Thank you. That would be good.
Yeah.
I have another one. Following a stem cell transplant, what's the longest you have seen Revlimid continue to work as a maintenance therapy without a relapse?
The longest patient I've had has been on Revlimid now for 12 years.
Oh,
So, it's funny. That's a long time, obviously. And you think of the cost of this, Revlimid is incredibly expensive. The cost of medicine is driving all of us here and it's crazy. So Revlimid for 12 years is over $1 million of Revlimid. I mean, it just seems, it shouldn't be that expensive, but that's what it is. I mean, obviously it keeps patients alive, keeps them free of disease, but the cost of these drugs somehow has to go down. And I don't know what stops that from happening. And not that I want to pick on Revlimid, but the other thing that drives me crazy about Revlimid, it doesn't matter if I give you 25 milligrams, 10 milligrams, or 5 milligrams, they charge us the same for it. And that doesn't make any sense to me either. But
yeah.
so 12 years is the longest patient I've had somebody on Revlimid for. Went through a transplant, placed on Revlimid, and they're fine 12 years out after transplant. No evidence of myeloma coming back.
That's great. That's amazing. That's really good.
Yeah.
Can you talk about the current information about effectiveness of the COVID vaccine for us and if we need to take any special precautions? This was brought up at our other discussions too. It's a hot topic.
Yes. It's a hot topic for all of us. So we've looked at some patients who we vaccinated after transplant and after getting chemotherapy. And it's clear to us that some patients don't have an antibody response to the COVID vaccine. So I caution everybody who's getting chemotherapy, even if they get the COVID vaccine, they have to be very cautious about all the mitigation strategies to prevent developing COVID. I am worried that some of our patients who are getting COVID vaccines aren't fully vaccinated, even though they get both shots. For whatever reason, the chemotherapy they've had or whatever things they're going through with their underlying cancer is preventing their cells from reacting appropriately to the vaccine. So I recommend everybody get the vaccine. I recommend to try to schedule it within and not have any of your agents for your cancer 2 weeks before and 2 weeks after the vaccine if possible, just to maximize the response. But I'm saying that without any data. When we look for antibodies, which is what you look for a vaccine response in patients under therapy, many of our patients haven't made any antibodies. So that's a little bit disheartening because that's the only thing we could measure that shows the vaccine has worked. Having said that, it may be you don't need the antibodies to prevent or improve your chances of not getting the COVID infection. So that's one thing we can't tell for certain. So I urge everybody even to get vaccines, but even after vaccines, unfortunately, I think we need to remain very cautious and use all the mitigation strategies we can to prevent any sort of infection. And as you know, even patients who aren't going through cancer therapy have gotten vaccines and have gotten COVID. So it's not 100%, and it may be less than that in cancer patients. When all the trials were done, they didn't have any patients who had cancer therapy in any of the trials that looked at the initial COVID vaccine efficacy. So we really don't know how efficacious it is in cancer patients. Patients on therapy, patients on Revlimid, patients on Velcade, that conceptually that may prevent your ability to mount an immune response and be appropriately vaccinated. So that's what worries us. Unfortunately, we still recommend, and the recommendation from the American Society of Clinical Oncology, American Society of Hematology, is try to get every cancer patient vaccinated, regardless if they're on therapy, and see if this helps us without knowing really what the prevention will be with the use of vaccines in our patients.
Another question related to this, will the finger prick antibody test help reduce concern?
So it's good if you have antibodies. We're a little bit more concerned if you don't have antibodies. I don't know what the finger prick antibody test is, and I don't know what the reliability is. When we do it here, we send it to our laboratory with a full blood sample. So I don't know how reliable that finger prick antibody test is. I'm just a little worried about that. Again, even if you don't have the antibody, you may be protective, but there's no way we can measure that. And the only thing we can measure is the antibody.
Okay, let's see. For patients on Revlimid maintenance for 18 months, do they show a suppressed response to the COVID-19 vaccine? Kind of the same. Sort of.
Yeah, we don't know that yet. We have to get more information. We're trying to get that data right now, actually.
Yeah. Can we get titers or antibodies drawn to know if we had a response? It's the same. I think we're talking about the same thing.
We can. And again, I caution everybody, even though you don't get titers or antibody response, you still may have a response that we can't measure that prevents you from getting infected. But that's the only way we can measure any response right now. So we're kind of in a dilemma with this.
So another question is, if a multiple myeloma patient does come down with COVID, are there specific treatments or what should they do? Is there anything specific or special that they should do to get rid of this faster or
Well, I think I think the current recommendations are if you have symptoms and you test positive with COVID, I think the first thing is decide whether or not you're sick enough to go to the hospital. And we usually base that on if you're short of breath, if you're coughing, if you're not feeling well. If those things happen or you have high spiking fevers, that's probably time to get to the hospital. But realize some patients get COVID and they don't have any of those symptoms. They don't have severity of those symptoms. And in those patients, we're just recommending they stay at home and just monitor what happens to them. There is some therapy that we can use as an outpatient that sometimes decreases the symptomatology of COVID infections. So that is another option. So there's an antibody therapy that's been approved by the Food and Drug Administration that we can administer as an outpatient to patients with COVID. So that would be an option you can investigate with whatever physicians you're working with. So as an example, we're giving that treatment to one of our patients who developed COVID 2 days ago, not requiring hospitalization, but we've elected to go ahead and give her this antibody treatment as an outpatient with the hope that this decreases their chance of getting worse symptomatology from the COVID. So it's administered as an outpatient, it's IV infusion. It's a two antibody combination cocktail.
Are the antibodies produced from the vaccine the same as the antibodies produced from having COVID?
We think so. I think most of the data suggests it is. What they have found that if you have COVID and you get the vaccine, it does boost your antibodies. So there's antibodies you develop normally from the infection, but that can be boosted quite well, at least in patients who aren't on cancer therapy with the vaccine. So patients should get vaccinated even if they've had COVID already.
Right. And Hal Anderson says that he survived COVID pneumonia thanks to remdesivir and Dex.
So that is one of the therapies we do use for those. So good, I'm glad. It's tough disease on patients.
Yeah, it's good to know this. I mean, really, this is a nice thing for a chat like this is if you have comments too, raise your hand, put them in the chat or anything. I mean, if you know something about how this has affected you, this is good for all of us to learn and know.
And there is treatment for COVID. There's treatment that does reduce symptoms. Some of those treatments can be given as an outpatient. So it depends on your symptomatology and how you're feeling, whether or not that would be administered. So, if you do get COVID, follow up with your doctors, I think, and see what's available because it changes quite quickly as well.
Right. Recommend. Okay, this just came to. If a patient has a complete response to a stem cell transplant for 18 months, do you recommend a second stem cell transplant at the time or wait longer? What are the factors that determine the timing of a second transplant?
So, we don't do a second transplant unless you've showed evidence of progression. So if you're at 18 months and everything looks fine, there's no evidence of progression, we don't recommend a second transplant. If you go 5 years and the myeloma comes back, then we may recommend a second transplant. But we don't routinely recommend a second transplant right now. unless there's evidence of progression of your myeloma after first transplant. Other centers may have a different approach, but that's what we've recommended.
Any other questions? I think we've gone through the chat here and the ones that I've gotten in advance. Anyone else? Just unmute and speak up. Let's keep the conversation going.
Dr. Uberti, thank you for your information. When I was originally diagnosed with multiple myeloma, it was because my bone structure and osteoporosis had really kicked in at a really high rate. And I was of the impression, I'm now a survivor for more than 2.5 years and patient of Dr. Zonder. And in one of the studies where you go on maintenance for 2 years or indefinite, I got randomized into the 2-year portion. But all that said, recently I was told that I'll have to stay on Prolia for a long period of time because of the osteoporosis. My concern is with the side effects of Prolia, are there other drugs that would, help your osteoporosis that maybe don't have some of the side effects of the Prolia? That's my first question. And the second part of that question is, if my myeloma were to return, would it be masked because I'm getting the Prolia shots?
I think for the second part of the question, no, that shouldn't be masked by getting the Prolia shots. And usually there's symptoms and signs that the myeloma is coming back. There are other bone strengthening agents available. I don't know why Dr. Zonder picked that over anything else. Have you discussed that with him? He's the expert at this sort of thing. He needs to give you the
Actually, he didn't pick it. My endocrinologist did.
I see. And what did Dr. Zonder say about that? Have you spoke to him about it?
He more or less went along with it. I haven't asked him this direct question.
Yeah.
I will be asking it now that you mentioned it.
Yeah, I would ask them and see what they think. There are side effects to all the different agents that help bone reform. That is one of the tough things of multiple myeloma is the loss of bone strength, the lytic lesions. Sometimes those never heal up, even though we've gotten rid of all the myeloma. So the best we could do is strengthen them a bit, but sometimes those lesions remain. So I think, we want to prevent that bone loss from continuing. So even though we might not be able to reverse it completely, we do want to keep it from getting worse, because that's a bad thing that happens to patients with myeloma. So it's important to try to prevent that. What the best agent for that is based on all the side effects. Why don't you talk with your endocrinologist and Dr. Zonder about that? So I think they can weigh in and give you what other options may be available if the side effects of the Prolia are too difficult for you.
Thank you.
I did get one more question, actually, just through my email. The incidence of secondary cancer with Pomalyst.
So we don't know what that is. We haven't used it as much as with Revlimid. So whether or not it's the same as Revlimid or less than Revlimid or more than Revlimid, we don't know. So we don't know. The easy answer is we don't know.
Dr. Uberti, another patient of Dr. Zonder's. Last week I went in, I'm in the 8th cycle with treatment. And when I went in, they took my blood pressure, which has been high quite frequently, but never alarming high. Well, last week they stopped my treatment, and immediately admitted me to the hospital for my high blood pressure. So now they've put me on a different high blood pressure medicine and halted the treatment until the 27th when I go back in. Do you hear, I've done some research and it says that, Revlimid and dexamethasone can be culprits of a high blood pressure, but is that frequent where it becomes dangerously high?
Well, certainly steroids can be, I think, probably the major culprit of causing hypertension, and it can be dangerously high. So, we don't want to, it has to be treated. Now, why it happened all of a sudden, I'm not exactly sure. I don't know if there was a change in the medications or how they were using it. Usually it's something that happens fairly quickly after we start these medications, but it can happen more so with steroids, I think, and the high doses sometimes they use for treatment of myeloma. Revlimid perhaps can do it too, although steroids are the one that we really associate with hypertension and the development of that. So it has to be treated. Whether or not they have to change it or decrease whatever medication they think was causing it is difficult to say. So it does need to be treated. It must have been fairly high if they wanted to hospitalize you, because of a high blood pressure can cause strokes, can cause bad things to happen.
Right.
Sometimes they have to hospitalize you just to get it down very quickly.
Yeah, that's what they did. I agree with you also about Big Pharma. Years ago, I was healed with Harvani of hepatitis C, which I'm grateful for. But I saw a report where the drug that they paid, well, the insurance paid $127,000 for, found out that it only cost $1,200 to make.
I know. The drug costs, I think, are driving everybody crazy in this country, and I don't know what to do about it. I really don't. But I
Yeah,
think it's terrible for patients. It's terrible for us as a community that these drug costs are so high and preventing patients from getting adequate therapy sometimes.
it's
I don't know
unfortunate.
if anybody can afford any of these things. You have a 10% copay or 20% copay on a drug like Revlimid. I mean, that's a lot of money for anybody.
Right.
I mean, it's
Thank
not
you.
bad if it's $100 a month. It's bad when it's $12,000 a month or $20,000 a month.
It's unfortunate. Thank you.
Here's a related question. Are you aware of patients that switch to another maintenance drug due to the cost of Revlimid?
We do. So some patients can't afford it. So we generally, if somebody doesn't have peripheral neuropathy, the next drug we use is Velcade usually. So Velcade, part of the problem here is how patients pay for drugs that are their oral chemotherapy versus chemotherapy that's administered in a clinic. So chemotherapy that's administered in a clinic, such as Velcade, as an example, the insurance picks up the cost of that. But when we give you Revlimid, a pill as an outpatient, the insurance doesn't pick up all the cost for it. So it's a dumb situation how they've done this. Because sometimes patients say, I can't afford this. So we give them Velcade instead.
Is it possible to create Revlimid in an injection format so that it's not a pill anymore?
We wish. There's certainly advantages for patients to take a pill. The disadvantage is how much they elected to charge us for it,
Right.
and how much the insurances don't pay for it. I mean, the advantage of having a pill is so much easier than a medication you have to inject. So.
Here's another question, and then we're getting really close to the hour. So I will ask this question, and maybe we'll sort of start to wrap this up.
Okay.
When someone's AHD Zameda years ago for 2 years, and then needs to continue with reclassed for osteoporosis later, is the risk of side effects increased?
I don't know that the answer to that question. I don't deal with these bone strengthening agents too much because we usually refer it back to the referring physician to take care of those things. So I can't answer that question. I'm sorry.
Well, we're just about there. Does anybody have any other questions to ask right now before we end this? I think this has been very, very interesting. I mean, I've learned a lot, and I learned a lot at all of these, but I think it's been a real good conversation. And thank you everybody for all your questions. This is it helps move things along when you continue to ask questions. But if there's anything else you want to say, right now we're pretty much at the end, but we'd love to hear from you.
I want to thank all of you for allowing me to do this. It's been my pleasure really to do this. And I realize how tough it is for all of you to go through all these diseases.
Just one more thing.
Go ahead, sorry.
Are you aware of anyone that's had any success, writing to Congress people or whatever regarding the cost of Revlimid? Is there any route? I mean, I've thought about doing that, but I don't even know where to start.
I mean, I think we have a large influence on changing these things, but I think we have to do it. I think it's very important that we as a group, all of us individually, write our Congress people about this issue of the cost of all of our drugs. I think it's getting out of control.
And actually, just a little bit of conversations that I've had, and I don't know that much about all this, but Jerry said this in the chat too, that it was Jerry, the Michigan legislature is one of, where we can look to do some changes. And actually there are some changes that may be happening pretty soon. But it's because the cost of some of these drugs are different in different states. And some people who have two homes, one in like Florida and one here, have to make the primary residence in another state in order to get some of these drugs covered. And it does have to do with the way that insurance covers in Michigan different types of drugs. So,
as part of, we belong to a society called Michigan Society of Hematology Oncology, who is really arguing with our state legislature about an oral parity bill, which is what we want. Oral parity, that these drugs should cost the same inpatient and outpatient, and the insurance company should pay for them, because it's a unimaginable economic drain on outpatients when they have to pay for these oral drugs, and it's terrible. So the bill we're asking to fight for is called the oral parity bill, and it's been blocked for various reasons. Mostly the drug companies are arguing against us on this, which is kind of sad. And the
It
insurance.
was called the oral care bill?
Oral parity.
Oral parity, okay.
That the insurance company should pay similarly for the oral drugs we take as we do
Right.
for the things you get in your doctor's office through IV or sub-Q injections.
Right.
So.
all right, well, we are past our hour. So I do thank you again, everyone, and thank you, Doctor, for for taking the time, your valuable time, to answer all these questions and to be with all of us. We certainly appreciate it, and I appreciate all of you coming on too. So with that, I think that we probably need to let the doctor go do his work.
Thank you.
Thank you again, everyone. That was very nice. I'm glad I was able to provide some clarity, I hope, on this situation. Thank you again.
Thank you so much.
Hey, everyone. Enjoy your treats.
Yes, thank you for the treat.
Thanks.
All right. Take care.
Bye.
Bye-bye.